and my mentor, Colonel Dr. Sami, Colonel Dr. Sami, senior anesthetist and senior pain physician, my teacher, and assistant professor Dr. Saira, Sheikh Zayed Hospital, Rahim Khan, a very, very big support in conducting this session. This session will be about the brachial plexus block axillary approach, but our focus will be on the auxiliary approach, but we will go a little bit through other approaches as well. Since it's already 8:04, so we are going to the next slide. Okay. As we see, the brachial plexus or any nerve plexus starts or initiates as a nerve root, and then it intermingles, and then finally it ends up in terminal branches. Now, if we talk about the brachial plexus, it has roots that start with the C3, 4, 3, 4, 5, 6, 7, and then they form the trunks in divisions, and then ultimately the cords, and then further the terminal branches, which separately innervates different parts of the peripheral part of the limb or the upper limb, like hand. For about roots, if we want to block the roots, we will perform the interscalene block at the interscalene space, and with supraclavicular nerve block, we will block the trunks and divisions of the brachial plexus. And then with blocking the cords, we will go with the infraclavicular approach. And for terminal branches, like the median nerve, axillary, and radial nerve, we will go with the axillary approach. It's called axillary block for two reasons. First, it's done in the axilla. Secondly, all the references of all the nerves are around the axillary artery, which is the main reference point. And we keep that as a reference point and keep directing our needle around the axillary artery. And that axillary artery is the main thing with which we clarify all the anatomical structures around it in the axilla. Now coming to this slide. Okay, this is very clear. As you can see in the A figure, it is the interscalene approach. With interscalene approach, you can see it is almost innervation of the, except for the axilla part, the whole limb, upper limb is innervated. The whole limb is blocked, sparing the ulnar part. Then if you go with the figure B, supraclavicular approach, the whole upper limb is blocked. It's also known as the spinal anesthesia of the upper limb. Then is the infraclavicular approach. With infraclavicular approach, we can completely anesthetize or block or relieve the pain of upper limb, starting from elbow towards elbow to the hand. Then comes the axillary brachial plexus approach. With this, you can see the lateral part of the forearm is spared, which is supplied by the musculocutaneous nerve, and that nerve is separately blocked. It does not fall into that axillary artery reference points. It's separately present between the coracobrachialis and the biceps brachii muscle. You will further see that. Now, if with this figure you can see, first of all, if we clearly look at the probe position, this is the in-plane position. I think it may look a little blurred here. But if you look at the diagram or the picture, that this double A is the axillary artery, and it's enveloped in a fascia sheath. This is the axillary sheath, and in it you can see the axillary, that the yellow parts are within this sheath are the axillary, the nerves. Above, at 12 o'clock of the axillary artery is present the median nerve. Okay, these positions are not very, very specific or precise. At times, it may be a little 11 o'clock or 1 o'clock. And medially towards at 3 o'clock, 2 or 3 o'clock of the axillary artery is the ulnar nerve. And posteriorly, factually or in reality posteriorly, but on ultrasound, we can see inferiorly located will be the radial nerve. It may be at 6 o'clock or it may be at 5 o'clock. In this, you can see it's almost at 5 or 4 o'clock. Now we will go a little bit to the anatomical structures. We are going through these anatomical structures for the reason that once we keep a probe on a patient, the ultrasound probe, we may not see anything in any color. It will be either black or white. But once we have these figures in our minds, we can correlate and we can find the structures separately and we can identify them. It will help us. It will help us in knowing if we have really blocked that part of the nerve or not, or we have missed it. Since it's not a blind procedure, it's done with the naked eye and you confirm it, your needle tip precisely confirms that you have blocked the nerve or not. If we see the superior, one is brachial deep fascia. Now look at the figure 7, the round structure. This is the axillary artery. The figure 2 at 11 o'clock is the median nerve. As I said, the median nerve can be either at 12 o'clock, 11 o'clock, or 1 o'clock. Now it's here at 11 o'clock. The figure 4 is the ulnar nerve, which is always medially, but medially it can be at 3 o'clock or it can be at 2 o'clock. Then is the radial nerve at figure 5. It can be at 6 o'clock or 5 o'clock. Usually it's below the axillary artery. But all these nerves and axillary artery and this tree, the axillary vein, they're all covered in a sheet. If your needle tip has not pierced this sheet, so the drug is not going to anesthetize or give any analgesic effect to any of the nerve. It is going to be in another fascial plane. Now, if here we look at the figure 6, between the 8 and 10, this is the musculocutaneous nerve. This is the nerve we are going to block it separately. The 8 is the biceps brachii muscle, and the figure 10 is the coracobrachialis muscle. There is a fascial plane between the 8 and 10, the biceps brachialis muscle and the coracobrachialis muscle. And in this fascial plane, there lies the musculocutaneous nerve that I'll show you in a while, in second part of the session, which is a live demonstration on an individual. Now coming here, as we have gone through all the figures, the colored figures, now this is the ultrasound figure. You can see only the black and white structures. But as you can see, the artery will be pulsatile and it will be round in structure. So this is the A, this is the axillary artery. Superior to the, at the top of the axillary artery will be the median nerve, little medial on a 2 or 3 o'clock, it will be ulnar nerve. And here, as you can see, it's in the radial nerve is exactly at 6 o'clock, but it can be at 5 or 6 o'clock. It can be either directly below the axillary artery or a little medially. The musculocutaneous nerve laterally can also be seen. Now coming to this figure. Again, you can see, now, wait. This figure, it's of the right hand, right axilla. You can see all the structures, the axillary artery, the veins, all on the right, on the medial side, and the musculocutaneous nerve on the lateral side. It is for the right limb. Probe is of this block is for the right, or this sonography of the right limb. Now coming to this figure. This picture shows the anatomy of the left arm, left axilla. As you can see, the musculocutaneous nerve lying between the biceps brachialis and the coracobrachialis, and it's laterally, and it's on the and the axillary artery and the nerves surrounding the axillary artery are on the medial part of the figure. So this is for the left arm. Again, you can see now they have clearly marginated them with this cyan color. These are all the nerves. The artery can be clearly seen in next figure. This is it. This is the sonoanatomy. You can clearly now see the musculocutaneous nerve. It's present in a facial plane between the coracobrachialis and the biceps brachialis. This is a little clearly drawn figure. You all have to remember these structures, these colorful pictures, the sonography figures, these hand-drawn pictures, because now in a while, the second part of the session, in short while, we will be keeping a probe on a live patient, on a live individual, and we will be seeing all these sonography. We will be identifying them. This is the axillary innervation, cutaneous, motor, osseous, we can see. Okay. We went through the block initially, but now we will discuss a little the indications for it. Other than giving an analgesic block, we can perform complete anesthesia of the forearm and of the hand. We can perform all kind of repairs, all kind of surgeries of hand in axillary brachial plexus block. And if we, in support of the axillary brachial plexus, if we perform musculocutaneous nerve block, we can perform surgeries of forearm as well. Complications. Its complications are not different than from other nerve blocks. These are the same: the vascular puncture, the inadvertent intravascular injection that can end up in either arrhythmias or can end up in local anesthesia toxicity, and the direct nerve injury. Now, it is very important, if you are performing ultrasound guided procedure or any procedure, if you are doing even blind procedure with a needle, then the needle tip should not puncture, it should not damage the nerve. The more precise your hand is, the more good or the more skilled your hands are at ultrasound, there are more chances you are going to save to keep the there are more chances you are going to keep the nerve safe. You are not going to damage it. So that's why all these ultrasound guided procedures or any image guided procedures are preferred over blind procedures. There have been times when we used to perform these blocks blindly, going, and that would have been like puncturing going through and through the axillary artery, trans-arterial. First you go blindly. Once you see blood coming into your syringe and or your needle hub, then you would pierce it till the time that the blood stops coming to the hub and you will inject the drug. But that is very, very dangerous. If you are, because all anesthetic drugs would include bupivacaine, which is commonly available in Pakistan. At times lignocaine with adrenaline is also additionally added in 0.5% concentration. So once you putting any drug into the artery can be very, very hazardous for the patient. Okay. Before now this was the block, but I want to add something. Before performing any block, we always need to clearly clarify if it is indicated in this patient or not, if the patient is fit for it or not. Are there any what are the complications we are going to face, and additionally, if the patient is prepared, is he or she in a safe environment or not? So what we do after taking history or confirming he's not taking any thrombolytics or any testing that can increase the bleeding tendency, and that can compress nerves, forming hematoma, or additional complication can be aggravated. So what best is a proper history taking. Furthermore, the patient should be prepared with IV access intact and in a controlled environment, preferably in OT, with all resuscitative equipment available, including defibrillator. That is an environment where you are going to perform any block. There is a little assessment. Well, I'm sorry I have not deleted the answers, but let's go through it. Which one of the following nerves provide cutaneous nerve supply to the lateral forearm? As we can see, it's musculocutaneous nerve. So this is the reason we additionally block the musculocutaneous nerve with the axillary brachial plexus block. So it's actually 3 nerves there around the artery. This is the 4th nerve that we block. Regarding ultrasound guided brachial plexus blocks, what is more important is the ultrasound probe is placed transversely approximately at the level at the junction of teres major and biceps brachii. This I will show you. Rest all four are false. Like a low frequency probe is used? No. High frequency straight probe is used. Arm abduction over 90-degree may be useful in identifying vascular structures. No, 90-degree abduction is not important. There is a proper positioning for this block, and vascular structures are identified with the probe and their physical structures and their pulsatile nature. The landmark is the pulsatile hyperechoic axillary artery, which lies in close proximity to the nerve. This whole sentence is right except for the hyperechoic. The artery is always hypoechoic, and it's always like dark from the inside with a clear round margins. It can be performed only by an in-plane technique. No, it can be performed by both in-plane or out-of-plane techniques. Okay, what of the following? Which one of the following statements is false? The ulnar nerve lies lateral to the axillary artery. No, as we have seen and we have discussed, it lies medial to the axillary artery. Which statement is false regarding sonographic? Which statement is false regarding sonographic landmarks and axillary approach? The axillary vein should be used as a landmark. No, axillary artery is used as a landmark. So all are true. Median nerve usually lies at 11, yes, or at 12. Ulnar nerve lies at 2 or 3. Radial nerve 5 or 6. Plot position, yes. Axillary sheath is formed by the prevertebral. This is true as well. While performing ultrasound guided axillary block, operator should use a separate injection site to block all 4 nerves. Yes. Which statement seems appropriate regarding axillary approach of brachial plexus block? The musculocutaneous nerve generally lies outside the sheath. This is true. Usually within the body of coracobrachialis muscle. This is true. Now you can see this is again a revision of the figure that we have seen. It's the axillary artery that can be clearly seen, and then is the surrounding structures, as we can see it here. Now we'll be moving towards another part of the session, and this is the demonstration, probe demonstration in anatomy. Let me introduce you all to the ultrasound. This is an ultrasound machine with a screen, and this is a keyboard. In keyboard, we have different figures. We will only focus on the knobs or keys that are required for us. This is the zoom in, zoom out. That's usually called the depth. This is the gain, the brightness. This is the probe, straight probe. You can see it straight. Look at the position of hand. We will go up and down to see the superficial and deep structures. We will go medial and lateral. This part I have already marked it there. We will find the musculocutaneous nerve. Now I will show you in a while. If you focus in there, you can see a pulsating artery. I'm going to zoom it in. You will see it clearly. This is the artery. Once you press it, it's not compressible. The rest of the veins, axillary artery is compressible. You see? What I'll do now, I will add color flow to it to confirm it.
जी सर, अब ठीक है।
रेड जो नजर आ रही है, this is, ठीक है, जो आपको blue spot नजर आ रहा है, this is the axillary artery. I'm compressing it and it's not getting compressed, and it's round. See, now I'm removing the color flow. Axillary vein, another big round structure, hollow structure, dark, that get compressed and vanishes off. This is the axillary artery, the axillary vein. So the axillary artery, the round structure that you can see, and it does not vanish off even on applying pressure. This is the artery. this one. And this is the vein, the compressing one, which gets compressed. We already have confirmed it with the color flow.
Sir, which one is the mentioned by color possible?
Which one is the?
Which one is the vein, sir? Can you show us? Mention us, sir.
You are asking about vein? Give me. Yes, this is the vein. Now see here.
Yes, sir. Yes, sir.
This is vein. I'm compressing it. And now on the artery, yes, this is artery. It's not getting compressed. So what we are going to do, we are not going to inject any drug either in the vein or in the artery. This is why we do the ultrasound guided procedures. We need to see the tip of our needles. And now the medial or the lateral you are asking?
Yes, sir.
No, you can see the hold on. You can see do you see the musculocutaneous nerve? No.
No, sir.
Still no. Still no. Don't you see any white structure? As in, is white structure looking?
Yes, there is a white structure there. Sir, ये center में है, नजर आ रहा है. There's white
Yes,
structure.
this one is musculocutaneous.
This is the musculocutaneous nerve. And it is,
yes.
if you see my probe, the probe is on the lateral side of the artery. These muscles, the coracobrachialis muscle is laterally present of the two in the axilla. If you keep the axilla a reference point. Now, axillary artery, axillary vein. Now, if we keep this artery a reference point, we are going to zoom in a little to see if we can see any hyperechoic. Hyperechoic is actually a word used for a white structure. Anything that is getting very bright. On ultrasound, we call it. This is the artery. This is the point for which nerve? Median nerve. And this is the point for ulnar, below the artery, inferior at 6 or 5 o'clock. This is the point for radial nerve. We block 3 nerves here. This is the sheath. They all are present in. We need our needle. If you come from this point or this point, you need to pierce this sheath to block any nerve and avoid any vascular structure, giving drug into any vascular structure. Now look here. This is the musculocutaneous nerve. This is very clearly seen here. And it's very easy to block. Clear nazar aa raha on this ultrasound machine. So here we end up this session. We will go back to the
मैडम मशीन की क्वालिटी भी तो अच्छी है ना?
जी जी, आपकी बात सही है. और सर और बाकी ये कि जो प्रोब है वो एक्सपर्ट्स के हाथ में है, तो डेफिनेटली.
Every one of you is an expert, maybe better than me.
जी डॉक्टर साहरा ठीक कह रही है. माल वंडरफुल. मतलब ये इतनी अच्छी आर्ट जो आपने स्पेशली मस्कुलोकुटेनियस दिखाई है ना, इट्स रियली वंडरफुल. मतलब इस तरह नजर नहीं आती जमाल. वंडरफुल यार, माशाल्लाह. गॉड ब्लेस यू
सर. थैंक यू सो मच फॉर बीइंग हियर सर. और साकिब को भी सर थैंक यू सो मच सर. इधर सर प्रेजेंट हमारे साथ डॉक्टर सायरा और सर आमिर फुरकान भी सर. आई एम वेरी ऑनर्ड you all are here sir. And with this we end up the session. Now we will see the questions. What type of surgeries can be performed by performing brachial plexus using axillary approach? We already have discussed it. Now what is the drug and dosage? Drugs that usually are used is the bupivacaine, and with or without additional of the lignocaine with adrenaline. If you use simple bupivacaine, a volume of 20 to 30 ml in total, and the concentration of 0.25% is enough for the motor block. But if you go for the pain block, the pain relieving, then the concentration is further half into 0.125%, and even 15 to 20 ml is sufficient. Needle insertion in plane or out of plane, it can be done both. Nerve supply of forearm and hand. Forearm, as you said, the lateral part is supplied by the musculocutaneous nerve, and the anterior part is supplied by the median and posterior by the radial branch. Structure of the axillary sheath we already have discussed, and we have seen number 6. We have seen the musculocutaneous nerve location in a live patient and a live individual naked eye with ultrasound. And with this, I thank you all. And if anyone want to ask any question.
Jamal, I have one question. Do we feel a pop-up while piercing the plane or fascia? Or with experience,
Yes, you
will
always feel. No, sir. You always feel a pop-up if you are piercing a fascia. Like in tab block, if you are doing it, you feel 3 pop-ups. One is when you pop the skin, then the external, internal oblique, then internal and transversus. So even here, once you pop that fascia, you feel it with your own hands.
Thank you.
सर आप ब्यूपिवाकेन की कितनी कंसंट्रेशन यूज करते हैं फॉर सर्जिकल एनेस्थीसिया?
मैडम 0.25%.
और सर एनाल्जेसिया के लिए आप लोअर कंसंट्रेशंस यूज कर रहे होते हैं, क्योंकि सर कुछ पेशेंट जी सर कुछ पेशेंट्स बहुत ज्यादा कंप्लेन करते हैं क्योंकि सर्जरी के बाद भी बहुत आवर्स के बाद उनको वीकनेस रहती है अगर 0.5% आप यूज करें तो।
मैडम 0.5 is too heavy. 0.25 में तो मैं सारी सर्जरीज करवा देता हूँ।
And Dr. Jamal,
और उसमें कि आप सेफ्टी में भी लेते हैं।
Sorry, please continue. मैं फिर सवाल
जी बताएं।
मैंने कहा 4 to 5 ml for each nerve.
नहीं सर, इनका 4 to 5 ml सच नहीं है. This is 7 to 10 for the median and ulnar. रेडियल के लिए थोड़ा सा फिर ज्यादा यूज होते हैं सर, 15 to 20 ml रेडियल पार्ट में. रेडियल इज अ लिटिल थिक वन.
ओके फाइन.
तो यूजुअली आप अपनी कंसंट्रेशन 25 to 30 डिस्ट्रीब्यूट करते हैं. मीडियन बिल्कुल सुपीरियर पड़ी होती है, उसका 5 to 7 इज एनफ. अल्नर के लिए थोड़ा सा ज्यादा चाहिए होता है और फिर रेडियल उससे भी ज्यादा चाहिए.
एंड आप यूजुअली लगा रहे हैं व्हिच वन इज बेटर, 0.25% अलोन या मैं 15 ml उठाऊं 0.50% मतलब पॉइंट ये बुपिवाकेन प्लस 15 ml में लिग्नोकेन उसके साथ कर दूं तो 0.25, या ये ज्यादा इफेक्टिव होता है पेशेंट के कॉन्टेक्स्ट
सर मैं आपको बता देता हूँ 0.5% बुपिवाकेन उठाएं 10 ml और 10 ml डिस्टिल वाटर के अंदर उसको डाइल्यूट करें. सो दिस इज 0.25%.
नहीं ये नहीं कह रहा मैं, ये नहीं पूछ रहा मैं.
जी सर,
मैं कह रहा हूँ 0.25% बुपिवाकेन अलोन और मैं इसको लिग्नोकेन के साथ मिला के 0.25 कर दूं, इफेक्टिव पेशेंट के कॉन्टेक्स्ट में ज्यादा एज पर योर एक्सपीरियंस क्या बेहतर होता है?
सर ट्रॉमा के केसेस में वेयर यू सी दैट पेशेंट इज गोइंग टू हैव अ लिटिल मोर पेन आफ्टर द प्रोसीजर बिकॉज ऑफ द इंजरीज इन सराउंडिंग, तो उसमें सर लिग्नोकेन विद एड्रेनालिन ऐड होता है.
सर कैन आई ऐड समथिंग?
एड्रेनालिन पे थोड़ा सा वो करेंगे कि एड्रेनालिन नहीं ऐड करना चाहिए, बट ये सर उसका
अच्छा जमाल एक सेकंड, मैं थोड़ा सा अपना एक्सपीरियंस शेयर करना चाह रहा हूँ. वो अभी डॉक्टर साहब हैं, कोई मुझे नाम सॉरी उनका नहीं हुआ, वो बुपिवाकेन और लिग्नोकेन प्लेन का कॉम्बिनेशन जो है ना, इट्स वेरी इफेक्टिव. और कई दफा पैची जो हो जाता है ब्लॉक, तो कॉम्बिनेशन बहुत इफेक्टिव है लिग्नोकेन और बुपिवाकेन का कॉम्बिनेशन.
सर मैं यही कह रहा था 20 ml के अंदर 10 ml आप 0.5% बुपिवाकेन लें और 5 ml उसके अंदर आप लिग्नोकेन विद एड्रेनालिन लें और बाकी 5 जो है वो आप डिस्टिल वाटर लें. तो दिस इज अ कॉम्बिनेशन. सर ये आप लोगों ने हमें सिखाया सर आपने और सर साकिब ने. सर दिस इज अ वेरी इफेक्टिव,
वेरी इफेक्टिव. बिल्कुल पैची नहीं होता इसमें. वेरी वेरी इफेक्टिव.
एग्जैक्टली.
सर कैन आई आस्क समथिंग?
जी प्लीज.
सर अकॉर्डिंग टू हेडजेक उन्होंने कहा है कि आप लिग्नोकेन और बुपिवाकेन को ऐड ना करें बिकॉज जो ओवरऑल टोटल ड्यूरेशन होती है वो कम हो जाती है एट द एक्सपेंस ऑफ रैपिड ऑनसेट. तो अगर हमें प्रोलॉन्ग ड्यूरेशन चाहिए फॉर इवन पोस्ट ऑप एनाल्जेसिया तो वो हमारी ड्यूरेशन कम हो जाती है। तो दे सजेस्ट कि आप लिग्नो और बुपिवाकेन को ऐड ना करें। अगर आपको ब्लॉक करना है फॉर रैपिड ऑनसेट तो फिर आप लिग्नोकेन से करें, और पोस्ट ऑप एनाल्जेसिया के लिए फिर बाद में आप बुपिवाकेन का डाइल्यूट कंसंट्रेशन दें फॉर एनाल्जेसिया पर्पस।
ठीक है मैडम, हम तो पर्सनल एक्सपीरियंस के बता रहे हैं, वी यूज्ड टू डू इट। यूजुअली शुरू में हम सिर्फ बुपिवाकेन यूज करते थे, उसके इफेक्ट खत्म हो जाता था, फिर हमने लिग्नोकेन विद एड्रेनालिन कंबाइन करके इसके साथ, लिग्नोकेन प्लेन नहीं मैडम, लिग्नोकेन विद एड्रेनालिन, तो वो थोड़ा इंप्रूव हो गई, उसकी जो ड्यूरेशन थी काफी इंप्रूव हुई उससे। इस पे हमारे को रिसर्च हो भी थे, स्टडीज भी हम सीएमएच में करते थे, लेकिन स्टिल आई विल लुक इनटू।
असल में जमाल इसमें यही है ना, वो डॉक्टर साहब ठीक कह रही हैं, लेकिन ये है कि आप लिग्नोकेन से इसका रैपिड ऑनसेट ले लेते हैं और बुपिवाकेन अगर कॉम्बिनेशन में हो ना तो लॉन्ग का इसका बिल्कुल हो सकता है लिटरेचर में हो, लेकिन क्लिनिकली बुपिवाकेन लॉन और इन कॉम्बिनेशन मेरे तो ब्लॉक 3-3-4-4 आवर्स भी चले अल्हम्दुलिल्लाह, तो इट डजंट मेक एनी डिफरेंस।
जी जी सर, बस सर रिसर्च के ऊपर ही होता है किसी के इफेक्ट्स किस तरह आ जाते हैं, लेकिन जो मैडम भी ठीक कह रही हैं, शी इज राइट, हर सेटअप्स के अपने प्रोग्राम्स हैं।
Sir, can we add Presidex in it?
जी
Presidex.
Presidex, yes. Adjuvants can be added. Presidex can be added in. Tremol can be added in block.
Sir, at how much concentration of Presidex?
Sorry, 1 microgram per kg. 1 microgram per kg. Good experience. The overall analgesic effect prolonged from 12 to 18. It prolonged to 24 to 36 hours with Presidex, with an accurate or precise block confirmed with procedure was done under ultrasound guidance, not a blind one, sir.
Sir, can we have, sir, do we use a 0.5 or 0.25% of bupivacaine in axillary block, sir?
Yes, we do use, madam. 0.25 is a safe, dose to avoid toxicity. 0.25%.
Sir, for
in a volume of
anesthesia or for surgery, sir?
नहीं मैडम, मैं बताता हूँ मैडम, 0.25 is for motor block.
Yes, sir.
Motor block for surgery anesthesia. 0.125 if you further half this dose, that is for analgesia, for the pain. जी मैडम.
Okay. Thank you, sir. Thank you.
Jamal, thank you very much.
Sir, thank you so much. You all are here. Assalamu alaikum.